Alan Mendeloff, a member of the Wisconsin HFMA Chapter. Welcome to our video learning series for achieving the Certified Healthcare Financial Professional designation. As healthcare professionals, we work in a reform environment that requires entities to fundamentally rethink their business models. The new CHFP exam reflects this changing reality. A reform environment presents every healthcare organization with the same fundamental set of challenges: to identify new opportunities, devise creative responses, launch new solutions to achieve positive impact, and to sustain those gains. Our profession needs leaders who have financial skills and strong business acumen. In short, those with business savvy. The emphasis of HFMA's certification program is developing the skills needed to participate in shaping this business environment. A critical reality is that organizations today must be learning organizations that continuously measure and understand the business environment, translate goals into actions, execute effectively, and evaluate results. Our industry needs people who can lead change in a fluid world. So the purpose of the CHFP program has shifted toward continuous learning, not just demonstrating experience and expertise. A critical business issue is the recruitment, development, and retention of competent talent. The new CHFP program is intended both for individuals to use in advancing their careers and for organizations to use as a component of a comprehensive talent development program. The first of two modules is called the Business of Healthcare. This module's focus is on understanding the business environment from a financial perspective. Importantly, this module includes the business realities for payers and physicians as well as hospital providers. A fundamental business assumption in building the module's content is that CHFPs will work in a collaborative, multidisciplinary workplace, resulting from the transformation from providing care to managing health. The second module is called Operational Excellence, focusing on specific payer, physician, and provider business concerns. The second module will utilize case studies to present candidates the opportunity to see real-world business situations and test their ability to apply the knowledge gained in the first module. The second module encourages multidisciplinary thinking and appreciation of other professionals' business concerns. With these goals in mind, the chapters of Wisconsin, Connecticut, Arizona, and Vermont, New Hampshire have collaborated to bring you the following learning module. The topic to be presented is Cost Accounting Principles, and today's speaker is Kevin Boren, Chief Financial Officer for Essentia Health in Duluth, Minnesota. Prior to joining Essentia in January of 2014, Mr. Boren was the CFO at Mariger Hospital in Madison, Wisconsin, and he previously served as Director of Finance for Hennepin County Medical Center and began his career at Affina Health System, both in Minneapolis. Mr. Boren has an undergraduate degree in finance and an MBA from the University of Minnesota. He also earned a master's degree in finance and accounting from the London School of Economics. Mr. Boren is a fellow of the HFMA and currently serves as president for the Wisconsin chapter. Thank you.
Thank you, Alan, for that introduction. So, my name is Kevin Boren. I'm here to share with you Certified Healthcare Financial Professional, CHFP course, Module 1, the Business of Healthcare, and Course 3, which is on Cost Accounting Principles. So, we're going to walk through cost accounting, everything you ever wanted to know about cost accounting and more. So, it's fun. So, our learning objectives for today, we'd like for you to be able to define cost in the healthcare industry from multiple different perspectives representing in the, and also describe the varying types of costs in healthcare business and the ways that costs can change with volumes or services. So what is cost? I think what we hear about in healthcare a lot is that healthcare is too costly. We currently spend around 18% of GDP, or 18% of every dollar in the U.S. economy is spent on healthcare, and that is more than any other country. So cost is a heavy point of emphasis within finance and is a heavy point of emphasis within healthcare. So cost is not just important to manage margins, but I think in the healthcare industry is also important in order to keep our system financially healthy and to keep our country financially. And I think it really has an impact on making care accessible and affordable to individuals. So what is cost? Generally, a consumer would say that cost is the amount paid for the service. So cost is rather more straightforward in other industries where you don't have third parties involved in it. A consumer would call cost the amount that they're going to pay for something. So if I go to the store and I buy a stapler, it's pretty clear to me what the cost is for that, or a service would be similar. Cost, I think, is a little more complicated in healthcare. So we're going to talk about costs from a few different perspectives. One of the things we're going to focus on a lot today is internal costs. So what does it cost us to produce a certain unit of service? And that's using cost accounting or cost allocations. So the two are close, what the consumer pays and what it costs us to produce something, but they're not the same thing. And I think it's important to note those differences. Cost could also be defined from an insurer standpoint as the cost that they pay. Remember, the individual's paying some amount of cost out of pocket, the insurer is paying some amount out of pocket. So cost has a lot of different varying scopes, but what we're going to focus on a lot today is internal costs. So what does it cost us as a healthcare provider to produce a certain unit of service, and then how does that relate to our profitability and what we charge the patient? So there are types of costs. First of all, there's direct, which is direct really means it's on the unit or in the area of production. So if I'm in a hospital, and I'll use some hospital examples today, that would be like on a nursing floor is a direct care area. There's many areas of the hospital that aren't direct care, food service and clinic and administration and all those sorts of things. But in this case, the direct is in the area of production. That contrasts with indirect, which is in support of, but not on the unit, not in the area of production. And so an example of this might be administration. So it's away from where the care. Variable means that it flexes with volume. So it's a certain cost that's going to flex up or down with volume. So generally we would consider labor in a direct care area to flex with volume. If it's a weekend in a clinic, we're not going to have staff there. So that's a variable cost that flexes up and down at least slightly with the volume of people. That's contrasted with fixed costs, which fixed costs do not vary with the amount of volume. So this might be the amount of depreciation or the cost of owning an MRI. So that cost is going to be fixed. It's the same regardless of how many patients go through it in any way. Say we paid $1 million to rent an MRI over X period of time. That would be a fixed cost because it's not something that would. So some other types of costs, because really variable and fixed are not all the way, sometimes 100% applied. So the reality is somewhat more complicated in some cases. So one example might be semi-fixed. So a semi-fixed cost is something that's set or fixed for a set level of production, but can become variable later. So this might be a MRI. Let's say to my earlier MRI example, if we got a ton more patients this year than we had last year, we could add a second rented MRI. So that might be a semi-fixed cost. Step variable is something that varies with volume, but only at discrete units. So an example here might be a nursing unit. So if a nursing unit has one nurse to every 4 patients, there are certain thresholds where they're going to need to add a nurse and when they get another patient, and some thresholds where they don't. So let's say they're at 17 patients, right? They would need 5 RNs, but you go to 18 patients, and they would still need 5 RNs. That's an example of step variable where you're going to have those 5 RNs, and you don't need to add until you get to a certain point where you need to add. Goes over one of those. And then the last dichotomy here is really short-term and long-term. So I think it's important to remember time as one perspective when you're evaluating costs. So really, economists would say over a long term, all things can be variable, right? I mean, you can have more buildings, you can have more fixed equipment over a long term. So it's really important to remember the short-term duration or the long-term duration. Generally, in finance, we're focused on short-term costs. So these are, you would say that a building is fixed. But over a longer term, I think we need to remember that we do control some of those other variables as well. Allocation, the challenge is what is actually the cost of providing a service to a patient? And this is really important to understand not only from a pricing and profitability and profit maximization standpoint, but also from a cost reduction standpoint. If we don't understand our costs, what it costs us to provide a particular service to a particular patient, I don't know that we have any ability to improve that cost over time and to measure that improvement. And as we get into healthcare reform, where I think more and more we're going to be challenged to reduce our costs in healthcare, I think cost is keenly important and is going to be something that we're going to harness a lot within finance to help in the healthcare. Cost allocations generally work on 2 principles. You have a cost pool, which is how much does something cost, and then you have a cost driver, which is how do we allocate that cost to the other departments. So an example might be administration. So we know that our administration, let's say our 5 of our top cost centers, we know what their salaries cost, their salaries and benefits and space. So there's a cost that's fixed for that. What then we decide on is the drivers. So how do we want to allocate that administration cost to the rest of the organization? And that's where the cost driver comes in. So in this case, we might choose the total number of employees because administration is helping to manage those employees. Or we might choose total revenues, where we're saying administration is responsible for overseeing the revenues, the services of the whole organization. And there's some other examples here. Accounting, you might choose total employees or total revenues because they're helping with both of those things. Housekeeping, square footage cleaned, might be how you choose that. And I think that's a good example because that pretty directly relates, right? So housekeeping cleans all square footage, and that effort is somewhat proportional to the square footage of each department. So we're going to allocate those housekeeping costs. Maintenance, similarly, you could do square footage or work orders related to specific pieces of equipment. Information services, you might choose number of users. So people who are actually using the computers and actually using IS to. And then human resources, I think a really good driver is number of employees because HR is involved in the onboarding, maintenance, performance evals, the ongoing discussions and management. So choosing the right cost driver for that cost pool is really key. And you can see in some cases there are probably a few good answers or things that you may have to evolve and test and try within it. So cost allocations really go to revenue producing departments. That's generally the way that it works, except in step-down examples. We'll talk about that later. And then non-revenue or overhead departments usually get allocated to revenue-producing departments. So that's generally the way cost accounting works, except with a step-down method. So hospital cost allocation, so following similarly to what we had just talked about. Let's say that this is housekeeping as an example. You can see for the housekeeping area, we decided to allocate this on square footage. you would need to do the allocation of housekeeping costs is you would need the square footage for all the revenue producing departments. Medicine, pediatrics, lab, x-ray. So we're really taking the square footage of the revenue producing departments. We're figuring out a percentage to total that's going to sum to 100%. And then really we're taking the total costs, the $25,000 that it takes us to administer housekeeping, and we're going to spread it proportionately to those different areas based on their square footage percentage of total. So that's a detailed description and kind of following one example all the way through. So a step-down approach is a little bit of a different approach. So this is what's used on the Medicare cost reports, and some organizations use this method as well. What happens in a step-down approach is there's a defined order to how overhead is allocated, and it's done in that order, and some overhead allocations or overhead departments will get overhead from other overhead departments. So an example here is administration is allocating overhead to housekeeping, and then housekeeping is allocating overhead including administration to accounting before that goes out to the patient care department. So really the difference in cost allocation for step-down approach is the fact that overhead cost centers are quote-unquote fully allocated other overhead before they're allocated to the department. So it's not a good or bad thing, it's just a different way to approach this. But if you're going to do a step-down, you need a defined order for which overhead areas come first. And CMS does have a prescribed order that's used in the cost reports. Cost reports use this methodology in order to step down the cost down ultimately to the patient care center. So really it follows administration, housekeeping, accounting. It doesn't stay in accounting. Those costs are then allocated out to the So the outcome is the same, but it's a little bit of a different path and can lead to a little bit of a different. So activity-based costing is a very common method. And this is probably a little more commonly used, where really you have two steps. The first is you're going to gather total data and activity statistics, and then you're going to allocate the costs of activities to a service based on these statistics. So activity-based refers to the activity stats, so the stats that you're trying to gather. The cost drivers is what sometimes called, which are then going to drive costs of those services to the service departments. So this is an example or an illustration. So you can see for each department, you're going to have their annual costs. You're going to determine a cost driver, and then you're going to allocate to patient care departments or the service department their proportion costs. So registration and checkout as an example, we used visits, and you can see 4,000 and 1,000. So we have 5,000 total visits. So given our $25,000 in cost, the total rate per visit is $5, and then it's going to be allocated proportionately to medicine, to behavioral health, based on the cost driver. Similarly for medications, billing, all these other areas, you're going to come up with a rate per and a cost driver, a statistic that you're going to gather. You need to know the statistic in total and know the statistic breakout by area in order to drive the costs down to those specific areas. So you end up with a rate per service, rate per minute, rate per visit, rate per medication, and then you're going to drive it to those areas. So ultimately, annual costs here are $1.15 million. You would be allocating all $1.15 million to these two areas, medicine and behavioral health. In this case, we only have two. Many times it's going to be more than that, but you're going to allocate all total costs to these services. So setting prices is somewhat of a tricky thing in the healthcare industry. A lot of times prices are set by contract negotiation, some amount of history and market will determine what a provider's paid. Increasingly, providers are trying to use cost as a basis and cost as a way to allocate the amount of dollars that they're getting paid and making sure that they're being put in the right places. So when we think about that, there's a couple different ways to look at it. One is full cost, and really full cost pricing includes overhead costs. So this includes not only the direct costs we talked about earlier, how much does it cost us on the nursing unit to care for that patient for one day. It's also going to include the cost of overhead departments like administration, finance, HR, those sorts of things that don't vary, aren't directly related to the patient care and don't vary a lot based on volume. So marginal cost pricing is an alternative methodology, and that's really saying what is the variable cost related to producing that unit of service. So if I would produce one more patient, if I had one more patient show up at the hospital tomorrow, what would it cost us to provide care to that one? The difference between the two is really marginal cost does not have the fixed cost price associated with it. So as a provider, generally, you would not take less than your marginal cost, right? If you were being offered a price that doesn't even cover let's say the salaries for that incremental patient and the supplies for that incremental patient, obviously that would not be a good deal for the provider. But yet, full cost pricing is a tricky concept too, because who pays the overhead of an organization, and to what extent do they pay it? Generally, government providers pay less of the full cost than the full cost pricing, and more private insurers pay closer to full cost pricing. So this is an important lesson in that the concept of contribution margin, which is revenue minus the variable cost or the cost to produce that unit of service. A provider really doesn't want to accept any payment less than that. Otherwise, they're going to be losing for every incremental service or unit that they provide to that patient. So the concept of contribution margin, which I just talked about a little bit, is really just to say where revenues minus variable costs covers the fixed costs. So as I mentioned, there are some fixed costs in a hospital. Let's say the cost of the building. And this should say contribution margin. But the fixed costs of the building are met at a certain point. That's where you break over into profit. So as a simple example, if we had $50 in fixed cost as an organization, I would need to generate $50 in contribution margin. Revenue minus variable costs, dollars we get to keep after we paid the incremental, salaries and supplies on those patients. I would need to get to $50 in order to cover the fixed costs. At which point, after that point, I would be in profit, because every unit I would take in, I would no longer have to pay the fixed costs, and it would go to the bottom line. So this kind of an analysis is really important for providers in particular to know what their fixed costs are, what their contribution margin is per service, per payer, per service line, in order to understand where that crossover is, the point at which they're going to be profitable, where the revenue that they're taking in not only covers their variable costs, but also covers their fixed costs. Target cost pricing is a concept that's probably more broadly applied in other industries than healthcare, but is starting to really come around in healthcare. And so target cost pricing it's saying, hey, we're going to understand our cost of production, how much it costs us to produce a unit of service, and we're going to redesign that process towards a target price. We're going to set a target to say that we hope that we can provide X procedure for a certain dollar amount. And And then we're going to work to redesign the process in order to accomplish that, and then build in a certain amount of profit margin. So in some cases, you actually back into it. You think the market can give you, let's say, $20,000 for something. We want to make a 5% margin, and so we're going to shoot for a cost of $19,000. And then you're going to have to backward design and engineer a way that you can provide that service for $19,000. So I think this is an increasingly valid concept and something we're going to have to do in healthcare. One application of it is bundled payments. So if a provider wants to go out into the market and say, hey, I want to provide a total knee replacement for $20,000, they're going to have to really understand their costs to make sure that they can get to that amount and still have a profit, cover their fixed costs, and make a profit at the end of the day. So I think this is going to be a good and important concept for us to really focus on cost improvement for discrete diseases, for discrete procedures. That's what we're doing with it now. Target cost pricing for health plans is somewhat different. A lot of what health plans are contending with is how rate setting works. And so PPACA, which we mentioned in the earlier module, changed the way that rate setting works. So it used to be that insurer generally could set rates based on a group. And what that means is they would actually look at the people receiving the services. We would look at the characteristics of those individuals, the health statistics, the demographics, the genders, the industry, and then their history and their claims, down to how much care do these people use and what are the diagnoses of these people. What's happened in the healthcare reform bill and PPACA is, at least for exchange products, insurers are increasingly asked to rate based on a community. And what community means is it's really just based on age and geographic area. So it does not include things like health status, gender, or history of claims. And so it's a difference, and it makes a lot of difference from an actuarial perspective for insurers as they try to figure out we don't know all the characteristics of this population. We can't anticipate it. We also can't exclude people for pre-existing conditions, generally for exchange plans. And so we're going to have to deal with whoever accepts, pays a premium. We're going to have to accept as an HMO, and we're going to have to understand and deal with those consequences. So as we move into health reform and we move through a couple years into the exchange, I think this is something that's certainly evolving and something that HMOs are spending a lot of time on is how do they do their rate setting, how do they understand who's going to use what services within these areas, and they increasingly have a few more restrictions on that area where they're able to use for exchange plans fewer of these characteristics in their rate setting. So, but generally, an HMO is going to look at things much like a provider, and they're going to want to understand what the anticipated claim experience is going to be, what the demographics are going to look like for this population, who's going to sign up, who's going to be participating in this plan, and then what do their rates look like for the providers where these patients are going to use them. Break-even analysis is really the total cost and sales in the case of an HMO needs to cover their fixed costs. So they, like a provider, will need to reach a break-even point where they're covering their costs. HMOs also have a sort of variable and fixed piece. There's fixed costs as a part of the infrastructure of HMO, and they need to spread those costs over a certain number of members in order to reach the break-even point. And then for each of those members, they want to make sure that they're taking more in terms of premium than is paid out in premium, and that contribution margin, that revenue minus variable costs, revenue minus claims for that patient, that the sum of that is covering their fixed costs. In unit, for an HMO might be more like total membership. So it might be a membership point where where that HMO breaks even. So in summary, costs are really important, and healthcare managers, and particularly finance, we must be attentive to costs in order to remain competitive. I would say cost is a huge area of focus in the industry and is going to be where we spend much of our time, I would say, over the months and years to come as increasingly cost pressures are putting a damper on healthcare. And managers, must resist the temptation to maximize profits by cutting costs too far. We talked about this earlier in some of the modules about how you need to balance outcome and quality measures with cost measures in order to make sure that we're doing the right thing for our patients. Think about the triple aim. We need to do the right thing for the patient in terms of quality and outcomes, but also we need to address the costs, and we also need to can't push it too far where we're resulting in harm to the patients or failure to meet the services or needs of our customers. So the big challenge on cost, there's a lot of tools out there. I think this is an exciting module. There's a lot of great materials, and thank you for spending the time and get to know a little more.